Hey, sorry. Hey, everybody. This is Dr. McNamara here with Dr. Grafman and Goodin and Chanel on the technical controls. Welcome, everybody. We're about to have a conversation with Dr. Goodin about his project in the cognitive neuroscience of religion. He's looking specifically at religious experience changes and religious cognition changes in people with Parkinson's disease, because there's healthy literature on that developing the past 10 years with some subgroups of people with Parkinson's describing those kinds of changes. So Dr. Goodin is going to be following up on that and learning new things about it, new insights. So welcome again, Joel. It's good to see you.
Thank you. Thank you. Good to see all of you.
So Jordan and I like to remind our interviewees that the audience for these are not just other scientists.
Right.
You know, we're trying to reach students and the general public and just everybody who's interested in religion. And the tiny subgroup of people on the planet who are also interested in the brain. So speak generally, you know.
Right.
So the first question we have for you is, if you could please describe your study, your planned study, you know, what the research questions are, what kinds of methods you're going to be using, and what kinds of things you hope to find. Let's start there.
So I think the place to start is just that Parkinson's patients have long-term degeneration, pain, and that faith and spirituality is often a major aspect of how they cope with it. Their palliative care is what it's called in many cases, and the Parkinson's Foundation is looking more towards a palliative care sort of model of helping those with Parkinson's. The neuroscience of religious cognition tells us that there is this sort of there's some differences in the way that people experience Parkinson's, specifically with regard to whether they have left onset or right onset, whether it starts on the left side of their body or the right side of their body. And those that it starts on the left side of their body, and of course that means it affects the right hemisphere of their brain, we have empirical evidence from, like you said, the past 10 years or so that suggests that they have difficulty connecting or feeling connected, or almost like when you overuse your internet and it's sort of a throttling of sorts of your bandwidth. There's some sort of disconnection going on, or throttling or restriction of people with Parkinson's left onset, their ability to connect and relate to God as however they define God, sort of in socio-emotional and cognitive ways. So the way they think and the way they feel about God. So the general research question is just very generally is what's going on exactly. That's the central question of this study is how these these patients with Parkinson's are experiencing this different sort of different relationship, perhaps. We don't really understand it, but we know something seems to be going on. And the primary goal of this study is to better understand and clarify sort of how people may attach to God differently if they're left onset versus right onset. And of course, the hypothesis is the people with left onset Parkinson's are perhaps more likely to have lower scores on the religiosity measures, such as the BMMRS or the attachment to God inventory, different instruments like that.
So the method you're going to be using, you're going to ask them to complete these standardized scales. Any other particular methods?
We're covering a lot of bases because although we really want to be cognizant of the population we're working with, that they're going to be, maybe some of them are going to have a lot of pain, low energy, or just bursts of energy and then get tired quickly, might have tremors. All the potential symptoms of a person with Parkinson's. We want to sort of be kind and cognizant of all that, but we also want to not come back every few years and say, hey, one more question. So what we've tried to do is build the best set of instruments, and we're not just studying those sort of two instruments I mentioned, attachment to God and the BMMRS, the BIMRS as we call it. We've got a number of measures about personality, depression, anxiety, stress, affect. We're looking at that sort of over a four-week span through using the SPAIN is what it's called, the instrument. And then the depression, anxiety, and stress inventory is the last week. So that's sort of a different affective measure, which means just emotions, how they're feeling. And if they're really depressed, or if they're in an excellent mood, or whatever mood they're in is going to have an effect potentially on how they answer our questions. We're looking at disease management, social support, their engagements with other like romantic partners, family members, and then friends and community as well. And then we're looking at how they view, like I said, God, however they might define that entity. And looking at their God, their image of God, how they portray God in their mind, how they characterize God on the lambda is what we call that instrument. The BIMRS I mentioned, attachment to God. And we're looking at the credibility of how their parents behaved. If they were highly religious but abusive, that can have an effect on their sort of relationship with God, and maybe turning against the faith of their fathers or mothers or grandparents, for instance, any guardian or caregiver. Close relationships, psychological well-being, and sort of their idea of purpose in life, and how that's part of the overall picture. We're trying to get an overall picture. One thing I haven't mentioned, which you're probably waiting for, Dr. McNamara, is the dreams and REM sleep questions. We are putting that in because most people with Parkinson's have a history or present difficulties with some sort of REM sleep disorder, and sort of understanding how that can be sort of related to these other factors. It's something we don't fully understand. This is your area of expertise, so I should just turn that back to you.
Well, it's your interview. It's your interview, not ours.
It is, but I know in the experts in the room. So looking at, just making sure we don't just ignore the REM sleep issues and say that's not important. That would, I think, be a big missed opportunity. So it's a big study. It's got a lot of width and breadth and depth to it. It's full and comprehensive, but that's really what we want, is to get as much as we can in a short amount of time, and we're going to be as helpful as we can to participants as they run out of energy or need to take breaks, reschedule, things like that.
So a bunch
Can
of...
I ask a question first?
Sure.
Or do you want to? Go ahead, Patrick.
Sorry. So a bunch of surveys, but what I recall that you're doing that I find particularly interesting is the longitudinal component in in-depth interviews, about their spiritual life histories. I find that, that's going to sort of yield really unique data, it seems to me. You know, when you test them twice, you know.
In addition to the quantitative sort of surveys I just mentioned, we are doing an interview, and it is based on sort of life history and how people perceive their history in terms of like book chapters almost, and their religious, how religion played a part in that. It's not the emphasis throughout the interview, but we're definitely getting into that, and we're also not even emphasizing how does it feel to have Parkinson's disease and to cope with it so much. We're just trying to get their story, and we will analyze that qualitatively. As you said, there is sort of a time 1 and time 2 data collection. So there can be a lot of progression of Parkinson's disease over a 1-year span of time. So we're looking at this winter, the next few months, winter, spring of 2023 is where we currently are. We're looking at collecting both qualitative and quantitative data now and comparing the left onset versus right onset groups of patients with Parkinson's. But we're also going to come back to them. We're doing everything we can to keep them engaged in the study so that they come back 1 year from now, approximately, and do the survey with us again, do the interview with us again, and give us their story and how it may have changed, you know, from that time 1 to a year from now. So we'll be looking at across groups from left onset to right onset, you know, at the same time period, but also how left onset or right onset changes over time, and sort of comparing their progression or unfortunately digression in some cases.
So are you videotaping your interviews?
We are.
That's
We're
great.
recording all the qualitative data. We will have video. I'm not sure how we'll archive it in terms of whether we'll produce the video because of just wanting to de-identify and protect anonymity as much as possible and confidentiality, so that nobody can be identified. But we'll at least have the audio or the transcript of the interviews, and we'll obviously have the quantitative data as well.
As you pointed out, Parkinson's disease is a progressive neurodegenerative disease. And I guess some of our viewers may want to know when are you going, what's your criteria? Do you want Parkinson's patients after a first visit to a neurologist, or are you going to try to enter them at any point in time in their progression?
Well, it's mainly on the front end of Parkinson's, and anybody that doesn't know, I'm just going to put this sort of disclaimer out there. My grant, like a number of the other sort of smaller grants under this umbrella of John Templeton Foundation and Cognitive Neuroscience of Religious Cognition, I'm somewhat of a non-expert. I don't claim the expertise that Dr. McNamara or Dr. Grafman have. And so in terms of my understanding of Parkinson's, you have to take it with a grain of salt, and please correct me if I get something wrong, because I'm not a neuroscientist, I'm not a neurologist or a medical doctor.
We're not asking you to confess anything here.
Right.
Not a confession. We just want to know more or less early or late Parkinson's. What do you think?
Yeah. So earlier Parkinson's, I believe that a lot of times people are, when they get diagnosed, is what I was trying to get to. When they get diagnosed, they've probably been sort of having symptoms for a while. I don't know how long. So we're not really worried about making sure they've had it a specific amount of time before they can be involved in our study. But what we want to do is protect the study and the rigor of the study, but also protect the participants in terms of their health risks and just energy levels. We don't want to try to get somebody who is bedbound or wheelchair bound. All their activities of daily living, they can't do any of them themselves. So they're probably in maybe what would be called stage 4 or stage 5 of Parkinson's. There are 5 stages, and stage 4 and stage 5 especially, they're going to have health criteria, health characteristics where they're probably not going to have the energy and the health and maybe the ability to even expend the energy of talking for any length of time about the study. So we plan to not necessarily exclude them just from the start, but definitely to look at their symptoms as they describe them. If they want to be involved, still look at their symptoms as they describe them and say, we think this study might be, we're predicting that we would be asking too much of you if you're in that stage 4 or stage 5 of Parkinson's.
So I can very easily imagine the significance, once you get your results, the significance of those results for helping people with Parkinson's who happen to also be open to using spiritual coping strategies, let's say, because the kind of information you'll get will really help to identify, the most effective coping strategies for those people interested in using spiritual and religious coping strategies. So that, there's a clear clinical significance to the study, it seems to me. What about the scientific significance? Let's say you do find that there is less or a faster decline in measures of religiosity, however you want to measure that, for the left onset group. That they both at baseline and at time 2 are exhibiting lower scores on religiosity than the control group, the right onset group. So let's say you find that. What do you think would be the scientific significance of that?
I think there's sort of a short term, sort of in the moment. What do we do now that they're whatever age, 55, 65, and they're experiencing that? How can we support them there? But also the other part of that is how can we use that in a predictive way to sort of plan for what people with Parkinson's might, or to even predict the onset of Parkinson's in some ways. That gets into more of the details of REM sleep disorder and what might be happening around age 40 that could be predictive of Parkinson's disease later in life. But just clinically for those that are having trouble connecting to, let's say that a person is Muslim and they've sort of they've depended on Allah, all of their life, and they've got this sort of relationship, almost like a mother or father, which is often why we have attachments to God, however we might define God. And then we suddenly start losing that sort of feeling of connection alongside a brand new progressive degenerative disease that we would normally use our faith and beliefs and religious practices to sort of implement, to cope with this new disease that is probably tearing up our lives and just changing it, flipping it on its head. These people are sort of lacking a primary coping skill in some cases. Some people don't depend on God sort of in the same ways or as much perhaps. But for those that do, and for those that do even just a little bit, we need to understand that and how we can support them, and perhaps think of other coping strategies that and also understand their experience of that is part of their sort of symptom set, their symptomology of experiencing Parkinson's is not just maybe tremors, shallow voice, rigidity, all the symptoms, but we need to be aware that they might be losing a very important spiritual connection that they've enjoyed and appreciated all their life, and suddenly they're losing access to that. So losing identity in many ways, perhaps.
Dr. Goodin, how selective do you think that would be, though? If they're losing an attachment to God, is your thinking that it might be isolated? It's just going to be particularly with God because maybe they called upon God to help them through illnesses in a way that they wouldn't ask, say, a spouse or a parent or a child? Or do you think whatever you see in their attachment to God might be reflected in their relationships with other significant people in their lives?
Thank you, Dr. Grafman. That's an excellent question. And, the questions just remind me of things I should have said. So I did mention sort of experiences in close relationships, social support. We've got 3 measures that really look into sort of how people are attaching to the humans in their life, so to speak. The mothers, the fathers, the friends, the romantic partners. Of course, some of our participants will have lost or be widows or widowers. But how we're going to be able to compare how they've attached or how they're expressing their attachment to those human people, non-deities, I'll say. In most cases, humans are considered non-deities, except, the kings and queens of old, perhaps, that were given some sort of godlike characteristics in some cases. But normally, our friends and family, how do we attach to them? And then we're going to be asking those questions, and we'll have the data also about their attachment to God, to which we can compare and understand if it's just a religious, spiritual thing where it's just a disconnect with God or Allah or whatever spiritual force they believe in, or is it also affecting them in their daily relationships with friends, family, community, loved ones?
So are you going to select people a priori who say to you that I have a religious belief already, or would you take people without religious beliefs as well?
We're going to take anyone. I think the world of sort of, I'll say society generally, and I don't have a citation for this, so didn't bring my citations, but I think a lot of people are moving toward this spiritual, non-religious sort of mindset. And even the, other parts of the world that might have been previously agnostic or something, even atheistic, they might be more comfortable with maybe not the word spirituality, could be in some cases, but just sort of an attachment to energy. I'm thinking of Reiki therapy or paganism or something like that, where they're attached to just getting out in nature, and they feel comfort and sort of like there is some sort of force. They may not call it anything spiritual, but to them, it is something that is sort of comparative to what other people might describe as the Judeo-Christian God or Allah or Buddha. So to answer your question, I went the long way. To answer your question, we're taking anyone with any beliefs because we want to hear the voices and the stories of those who don't have these strong religious overt expressions and belief systems that they're talking about all the time. So
has religion been a part of your prior studies? What's been your research before you took on this project?
It's been minimal. I study generally I study resilience. So this does have some relationship to what I've studied in the past. I've gotten into sort of locus of control attributions that we make. Who's to blame for one study, very small study I did was who's to blame for Hurricane Katrina, and the ways we attribute blame and praise even, and make meaning of what happens to us that has an effect on our long-term health outcomes and success. And so I've studied things like that. My PhD is in EdPsych, educational psychology. So I've studied a lot of sort of resilience in med school and performance. Resilience is highly tied to performance. So looking at performance, especially in sort of high performance areas, high stress, high emotion, and high performance areas. So whether that be a pro athlete, or in this case, it'd be somebody going through a very difficult chronic disease progression. That's generally my history. I worked in geriatrics as well, so I've got sort of some of that to lean on as sort of a research coordinator at a med school in geriatrics. So
that background in resilience does seem really relevant for the issue of people with chronic disorders, you know, that just for most of them, it just gets progressively worse. And getting back to the issue of the scientific significance and what Jordan was asking as well. So if it sounds like beliefs may not change. So if somebody was believing in God, those beliefs will still be there, but the ability to easily access attachment representations or feelings are degraded. So it's like you were pointing out, it sounds like for the subgroup of left onset patients, they're facing this very difficult disorder at the very time also that they're finding it more and more difficult to feel the attachment to God that they used to use as a resilience factor in their life. So when they need God the most, he can't be found for some of them who feel that reduction in the emotional access to God. So that's quite a poignant picture.
I like the assist you gave me there, which is to point out they don't give up on their faith. They don't say, well, I've become atheistic towards whatever I believed before. They still believe it sort of in a almost purely cognitive way in terms of this is the fact I believe. What would be called doctrinal, probably. You can correct me on that. But so they still care about this religion and participating. So it's not as if it disappears. They still believe in it. They just can't experience maybe what they want to even experience. And apart from coping, a lot of people get joy, pleasure, comfort, all sorts of good experiences from their sort of daily walk or weekly walk, whether if they attend something on Saturdays or Sundays, a religious event, they get all sorts of sort of life support from their interactions with God. And I can only imagine sort of having that belief, retaining that belief, but no longer being able to feel it. It's sort of like, I don't know, I can only compare it to maybe marriage and not, knowing you still care about your spouse, but no longer being able to feel the same way. And that disconnect must be really uncomfortable.
I can imagine, yeah. And one last question on the scientific significance. So if you indeed find, broadly speaking, group differences with the left onset group, describing all these individual differences around attachment to God being more difficult for them relative to the testimonies you get from the right onset group. So if you indeed find that profile, and as you were saying earlier, the left onset indicates relatively greater right-sided brain dysfunction. Does that mean that attachment to God is mediated only by right hemisphere circuits?
It's a good question.
I would say no. I would say it would support somebody arguing
Right.
that, but
Well,
it's not definitive proof.
yeah, for those that are sort of maybe not scientists watching this, you know, in science, we just seek more evidence, more data, and we add to our body of knowledge and understanding, and sometimes a study will come along and change everything we thought was true. But in this case, it would, like you said, it would support this sort of hypothesis that there's something going on with the left onset Parkinson's disease affecting that sort of ability to connect to God. But no, it wouldn't be, you know, the theory has now become law in terms like the law of gravity. But it would sort of say maybe we're headed in the right direction scientifically, and we can start to look at clinical and practical implications for if this is true, then that. And sometimes the clinical and practical implications, if you start implementing those, you can see that hey, this is helping these people, and that can provide further support that you're headed in the right direction. If the treatment's helping in some way, then perhaps you had the diagnosis correct.
We interviewed Dr. Johnstone and Cohen.
Great.
And they have data, and they're going to collect more data around a hypothesis, again, that the right-sided parietal lobes are particularly important in relationship, the self's relation to the what they call the transcendent. When you say that, Jordan, that was their major focus. They're looking at the right
Transcendence.
posterior.
Yeah, the idea of transcendence, yes. I was wondering, actually, I forgot to ask this before, Dr. Goodin. Can you remind us if your Parkinson's patients are going to be getting DAT scans, D-A-T scans, as a way to look at dopaminergic activity, maybe in the frontal lobes or elsewhere, as part of their diagnostic workup? Do you know that?
Okay, so the answer is not as part of my study. So they may have it. That I believe that I don't know what percentage of people with Parkinson's disease get the DAT scan, but I know it is used sometimes sort of as a complementary or supplementary diagnostic tool to measure sort of dopamine activity. But no, not as part of my study. I wish, but we haven't decided whether to collect that data. It's currently not part of the plan, but now I'm rethinking it. So
Well, you don't have to rethink it so much as find out if they do it ordinarily, if the neurologists are going to be collaborating with on this study, do it ordinarily in their clinical workup. Some places do it, some places don't. But
right.
I know Patrick and I are interested in neurotransmitters, serotonin, dopamine, and their activity and how that reflects in people's relationship with supernatural agents like God. And so if it's out there, reach out for it.
Right. I get that information pretty easily. Working with two centers of excellence. One's bigger, so it's actually a true center of excellence. The other, that one's in University of Kansas Medical School, UKMC. And then the other one's in UAMS, Little Rock, University of Arkansas for Medical Sciences. And the neurologists are all extremely helpful. So I'll reach out and ask how often they do that.
Yeah, I think that if you can get it, that would be great, particularly if it was done in temporal, not too long before you see them, before you test them, But yeah, any brain data you can get on them is probably good. But
Yeah.
in any case, that's all the questions for me. How about you, Jordan?
Oh, I'm just hoping that your participation in this larger project, Dr. Goodin, gives you incentive to study religion as part of
Yes.
your resilience projects in the future, and to use that as one factor that maybe allows people to be more resilient than others if they have a deeper religious belief or not. Be interesting to see that in the general population and not just in Parkinson's patients.
Originally, when I went to med school, I was trying to, I think I was looking at primarily a PhD in counseling psych, and I looked at Rosemead School of Psychology at Biola in California. Highly religious, more of a Christian mindset, and I looked at the papers and the dissertations they were publishing, and all about Christianity. And at that time in my life, I said, I don't want to just study Christians. Coincidentally or ironically, I'm not sure, I've circled back to religion in my research journey, and sort of going through resilience and performance and stress. I've come back to at least getting to study religion, generally speaking, and not to be confined to just Christianity, but any type of faith system, or even those who are more agnostic or atheistic, that, you know, and sort of understanding that and framing that in terms of how they may not call it religion, but what type of relationship do they have to nature, for instance, or energy. So yeah, I think it will spur, and I'm seeing this study, looking at hopefully around 200 participants. I'm seeing it as a study to set up a future bigger study.
That's great, and we hope you keep the brain as part of the recipe of your research. You know,
for sure. I plan to, and hopefully continue to work with Dr. McNamara, who's on my team currently, and just become, you know, as I've gotten into this grant, I've become a little more networked, and plan to build on that, becoming networked with the other people that study religious cognition. So
we're glad to have you on this project. Thank you for joining us today.
Thanks, Dr. Goodin.
Such a pleasure. Thank you both.
All right.